Welcome everyone to our next session on the prostate cancer scenarios. We are going to discuss possibly intermediate and high risk prostate cancer, and we will try to include the metastatic prostate cancer and castrate resistant prostate cancer based upon the time. Thank you for the trainee who has kindly agreed to record this session, which is a very good source for future revision. So the scenario is you have a 72-year-old gentleman who is fit and well otherwise, no major comorbidities, no family history of prostate cancer. He presented with increased PSA of 13 and his baseline MRI was PIRAD 4 occupying posterior zone of the prostate, 50 cc prostate with a PSA density of 0.18. He had his biopsy. He had all the 5 cores of the targeted biopsies positive, showing Gleason 3+4, and 5 out of 24 systematic biopsies also showed Gleason 3+4. Lymph node invasion present, 60% of the core involved in at least 3 cores. So what are the options for him?
You said lymph node involvement present as well.
Yeah, in the cores, yeah.
Yeah, he has got a high risk prostate cancer, which is locally advanced prostate cancer. The options.
Sorry, Sachin. Sorry to interfere. It's a lymphovascular invasion in the prostate cores. Lymphovascular invasion.
Yeah. So, according to the NICE guidelines, he is on intermediate risk prostate cancer with possible local invasion as well. So I would bracket him as a high risk locally invasive prostate cancer between ISUP between 3 and 4 at present. His options would be based on his shared discussion. I will take this biopsy results through the MDT, and I'll meet him in the cancer clinic with cancer nurse specialist. I would explain him about the biopsy results, and his options further would be radical treatment, which is based on curative measures, and that would be radical radiotherapy as a first line of recommendation, along with radical prostatectomy, with the possibility of radical radiotherapy in the future.
Okay, so why do you think he may need radical radiotherapy when he is going for radical prostatectomy?
This is based on EAU guidelines, where it says high risk, locally invasive, locally advanced prostate cancer, and my feeling of lymphovascular invasion here is a high risk, and he may need further multimodality treatment along with radical prostatectomy, but this will also depend on the post-operative specimen histology as well at the same time.
Okay, you need to differentiate between the actual lymph node invasion and lymphovascular invasion. In the prostate core biopsies, when they report lymphovascular invasion, it means within the prostate there is evidence of adenocarcinoma which is involving the lymphatics or the vascular structure within the prostate. It doesn't really mean that the prostate has had like a capsular breach and then extending into the lymph nodes outside. If the MRI shows lymph node involvement, that could be a positive lymph node involvement. But in the core biopsies, if it is lymphovascular invasion, it is intraprostatic lymphovascular involvement. Sometimes even in the biopsy, they may show that there is sign of extensive spread, etc. But don't take that as equivalent to locally advanced prostate cancer.
Okay.
Other than that finding, how are you going to classify or risk stratify him?
Yeah, I'll reframe my classification. He is high risk, intermediate risk prostate cancer with ISUP 3 scoring, and in Cambridge prognostic group, he stands at Cambridge group 3. After the running through MDT, his options would be radical prostatectomy or radical radiotherapy along with androgen deprivation treatment for at least 1 year. and versus not recommended at this point is active surveillance. Yeah.
And when you say about the radical prostatectomy and radical radiotherapy with adjuvant hormones, you can complete by saying that with curative intent, because that is our aim.
Yeah. Yeah.
And how are you going to further stage this patient? Does he requires any further staging?
Yeah, he would require further staging of bone scan to start with, and because of his PSA being more than 10, I would get a CT thorax as well for staging.
Okay, the role of CT thorax is very questionable. It's very rare for somebody to have a thoracic metastasis. There is a role for CT abdomen and pelvis to quantify the complete lymph node staging. Again, bone scan, what is the positivity rate for the PSA?
Bone scan less than 10, it's 2.3%, more than 10 to 20 is 5%, and more than 20 to 50 is about 16%. Anything PSA more than 50 would be more than 90 to 100%.
Okay, so how will you going to counsel this patient? You said the options. What are the possibilities?
I would counsel him according to the Bow's information leaflet and prostate cancer group guidance leaflet. I would explain him all about risks and benefits of each, including radical prostatectomy and radical radiotherapy, along with androgen deprivation treatment. In radical prostatectomy, I would inform him about the immediate and further the delayed risks involved in the procedure. Immediate risk would be bleeding, infection, injury to the surrounding structures, and clots happening in the legs and clots happening in the lungs. In terms of delayed complications, I would inform him about urinary incontinence, for which he should have to start pelvic floor exercises from now on to reduce the risk. At 6 months, it would be around 60%. At 6 years, it is less than 20%, between the range of 10 to 20%. Erectile dysfunction, long-term erectile dysfunction, about 60 to 70%. And urethral stenosis, bladder neck stenosis, and this would be my radical prostatectomy. And I would explain him about the routes, the channels that we can perform this, which is open laparoscopic and robotic assisted laparoscopic technique, and individually taking through all of them and risks and benefits of each procedures. I'd also mention that with the current scenario, we are doing this under robotic guidance, and this as such does not have any oncological advantage over the open procedure. However, this reduces bleeding, decreased blood transfusion in the immediate post-operative period, and early recovery with decreased hospital stay. I would also go and explain about the radical radiotherapy. I would like to give this information along with a radiation oncologist or a clinical oncologist alongside me as well.
Okay. Before going to the radiotherapy related things, you can include that you will include or update the patient regarding various support groups available. So there may be a patient support group who had previous radical prostatectomy, which may be quite good resource for the patient to share the ideas and understand the post-operative outcome. The support groups are very good for radical cystectomy, but nothing wrong in bringing them for the radical prostatectomy also. What is the evidence behind the radical prostatectomy?
Radical prostatectomy evidence comes from a PROTECT trial, and which measured the outcome from active monitoring radical prostatectomy and radiotherapy. Initially, it did not show major survival benefit. However, on subgroup analysis, it showed further evidence on intermediate risk prostate cancer with overall survival and also metastatic free survival. Again, this has been shown in a couple of other studies, which is Scandinavian Prostate Group study and Pivot study from US. Again, a similar way, they have showed improved advantage in intermediate risk group prostate cancer, along with any patients more than 65-year-old as well.
Okay. Is there any role for adjuvant hormones prior to radical prostatectomy?
There is no role for neoadjuvant hormones at this point, as a lot of previous studies have shown it, although it reduces the positive margin rate post-operatively, it has not got any survival benefit or metastatic free survival benefit.
Okay, so how will you explain the pros and cons of robotic versus lap versus open with the patient?
I would firstly mention that both surgical options here, open or robotic options, lap assisted, is done as a curative intent, and the oncological outcomes are the same. In relation to robotic and open, robotic is, although it uses a little more time in terms of operative time, about 1 to 1.5 hours more, it has got decreased risk of bleeding intraoperatively, decreased transfusion rate, early recovery, and decreased hospitalization at this point. And it has got improved advantage in erectile dysfunction post-operatively and urinary incontinence post-operatively when compared to open procedure.
Okay, which patients you will plan for lymph node dissection?
Lymph node dissection, as per the NICE guidelines, I will follow the Roche formula, which is 2/3 of PSA plus Gleason 10-6. If the lymph node status is more than 5%, I would counsel him for pelvic lymph node dissection as well.
Okay. Now, heading towards radiotherapy, how are you going to explain this to the patient?
Radiotherapy, this is involvement of radiotherapy. It can be as external beam radiotherapy or brachytherapy. I would explain him about the risks and benefits of the procedure. Again, the benefit is of curative intent. The risks are immediate risk, which can be related to bladder, bowel, and lower urinary tract symptoms. He may have increased frequency, dysuria, hematuria. He may notice features of bleeding from the back passage secondary to proctitis. He may have a urinary incontinence. However, this incontinence will be a decreased rate when compared to surgery, and he may notice erectile dysfunction as well. This radiotherapy will be associated with starting of androgen deprivation treatment 6 months, at least 6 months prior, during, and post radiotherapy as well, which can have its own implications on systemic effects, which is fatigue, and decreased libido, decrease, feeling weak, and with other hormonal effects as cardiovascular risk and osteoporosis.
So what is the dose you are planning for if you are planning EBRT?
That would be as per the CHIP trial, and according to the NICE guidelines. Now we have started on doing hypofractionated hyperintensity radiotherapy, which is 60 gara in 32 fractions. 60 gara in 20 fractions, and if they are not, if they cannot receive it because of some other reason, they can be given 74 gara in 37 fractions.
Okay, that 60 gara is in 20 fractions. The 20 fractions are 5 days a week for 4 continuous weeks with Saturday, Sunday as holidays. Okay, So, what is the use of having this androgen deprivation treatment before radiotherapy?
As per URTC, Bulla et al. Randomized control trial showed that having uh, androgen deprivation treatment alongside radiotherapy has increased overall survival from 40% to 78%, and progression free survival from 50% to 76%.
Okay, explain about the brachytherapy.
Brachytherapy, as per the new NICE guidelines, based on the Cambridge prognostic group study, is indicated in Cambridge group 2, 3, 4, and 5. It is brachytherapy is now further divided into low dose and high dose brachytherapy. Low dose is the brachytherapy essentially can be given alone or along with the booster dose, along with the EBRT, external beam radiotherapy, and this is mostly indicated in CPG group 4 and 5. Now, brachytherapy is divided into low dose and high dose brachytherapy. Low dose is normally given using iodine 125 isotopes, which or palladium. This is given over a long in taking place in implanting the pellets, and the radiotherapy is given in weeks to months. Patient has to be aware that they can irradiate their family members. Hence, they should be away from the pregnant women, children as far as possible, and also impacts on sexual intercourse. They have to use condom barriers, contraception. When comparing to the high dose brachytherapy, this involves iridium 191 pellets and given through plastic sheets as an access sheet, and this takes minutes to hours, and it is given higher doses, about 150 gyri, and this has risks of low risks of high intensity at the time, but it has not got any implications on their family members.
Okay, so it's iridium 192, not 191. Okay, and the main side effect differences you should know between the low dose and high dose. Acute side effects for low dose resolves over months, while high dose it will resolve within few weeks. And as you said, there is no radiation of the patient carriers in high dose. That's a good advantage. What is PSA bounce?
PSA bounce is a benign rise of PSA, usually happens after EBRT or brachytherapy. Usually it happens after 9 months, but within 12 months, and the PSA value should not go above 1.5 nanogram per deciliter.
Okay, it's happened 30% after brachytherapy, can happen even with EBRT also. Okay, what is the role of radiotherapy after surgery? Whether it's like adjuvant radiotherapy or salvage radiotherapy?
Radiotherapy as a multimodal treatment is being highlighted in NICE guidelines and as well the EAU guidelines in patients with high localized prostate cancer, mainly T3 and T4. And as a part of neoadjuvant radiotherapy, in some cases of lymph node positivity noted after the histological specimen retrieval.
Okay, so is there any role for adjuvant radiotherapy post prostatectomy?
And according to the as per the radicals trial, it showed that there is no formal role of radiotherapy post-operatively, immediate post-operatively. Hence, there is no role according to the NICE guidelines and the AU as well.
Okay, so how are you going to follow up a patient who had radical prostatectomy? What is the cutoff of PSA to do any secondary treatment?
I would follow him up after the procedure with a PSA test in our clinic with no less than 6 weeks, and would check another, keep checking the PSA 3 monthly for next 2 weeks. 2 years. In regards to his if there is any PSA climb more than 0.2, then I would perform further staging CT bone scan, and as per new guidelines from EAU, we can perform PSMA PET as well after 0.2.
So, what is the best investigation to stage them?
A best investigation is PSMA PET, but unfortunately, all the guidelines are written based on the CT scan and bone scan. Hence, we got to start with that. But best investigation to find if there is any metastasis or any recurrence would be PSMA PET.
So, how will you define biochemical recurrence?
A biochemical recurrence is defined.
Yeah, go ahead.
Defined if the PSA is more than 0.2 in 2 consecutive occasions after a radical prostatectomy, and if PSA is more than 2 above nadir in after radiotherapy.
Okay. So, in case if you have to start a patient on radical radiotherapy, how are you going to prepare him? In your clinic, if a patient decides to go for radical radiotherapy, how are you going to refer him? What you will do?
I would see him again with the cancer nurse specialist. I would refer him to the radiation oncologist for further advice for his radiotherapy, and I would give him Bow's information leaflet as well regarding the radiotherapy. I'm not sure if there is anything at this point I should be mentioning in terms of his preparation for radiotherapy.
Do you have to start him on the androgen deprivation treatment?
Yes, I would start him on androgen deprivation treatment 6 months prior to the radiotherapy. Would continue androgen deprivation during and post radiotherapy for 6 months.
Okay. Explain about the medication which you are going to start.
In our setup, we start the patient on anti-androgens, initially bicalcitonide 50 milligrams once daily for first 28 days. And after starting that, after a week or two, we will start LHRH analog, which is as the, sorry, I forgot the name, Zolidex. Zolidex to further for 6 months before radiotherapy, and the use of anti-androgens starting before LHRH analog is to avoid LH surge.
Okay, so it's goserelin. What is the dose?
Goserelin is 3.6 milligrams once a month, or 10.8 milligrams 3 monthly.
Okay, what do you mean by the flare-up?
As we give LHRH analog, it stimulates the secretion of LH and increase of LH, which would increase the testosterone level through hypothalamus pituitary axis. As this increases this increases the PSA and the cancer cells stimulation. So in order to curtail this, we start them on anti-androgen and then start LHRH analog.
How will you explain the side effects of androgen deprivation treatment?
It has got side effects of feeling mental health concerns in terms of depression. He may have cardiovascular problems, any thromboembolic episodes, metabolic syndrome, which is diabetes, hypertension, and waist circumference can increase. and bony problems like osteoporosis, along with sexual disturbances as well in terms of libido, erectile dysfunction, decreased or anejaculation sometimes.
Okay, so we'll move on to a different scenario. This patient presented with a PSA of 34. Biopsy showed limited biopsy done 10 cores. All the 10 cores showed Gleason score 4+4, and the bone scan showed presence of at least one metastatic focus at the region of L4, and also has multiple pelvic lymph nodes. How are you going to manage him?
This gentleman now has got a very high risk metastatic prostate cancer. I would see him in our clinic with the cancer nurse specialist, inform him about his investigation details, and I would tell him that he has got high risk metastatic prostate cancer, and according to the current EAU guidelines, I would start him on. I would start him on androgen deprivation treatment. I would also refer him to clinical oncologist to check if he's if he can have upfront docetaxel. I would want to, at this point, I would want to establish his performance score and also his renal function test to check if he qualifies for docetaxel.
He's quite fit patient. His kidney functions were excellent. What is the evidence behind the docetaxel?
The evidence comes from Chartered and Stampede trial, where upfront docetaxel in hormone naive metastatic group showed increased survival from 40 months to 60 months. And also the quality of life was increased as well.
Okay, so how docetaxel works?
Docetaxel acts on the DNA microtubules, and basically it acts on DNA microtubules and DNA fragmentation of prostate cells.
Okay, any idea about the dose?
Docetaxel is an IV medication, intravenous medication given in 3 weekly cycles of 6 cycles, and dose would be 75 milligrams per meter square.
Okay, it's given as an intravenous infusion, slow over 1 hour. Okay, this patient responds well to docetaxel, and further down he ends up having radiotherapy, keeping up with the Stampede trial, and he has got a good outcome. What is castrate-resistant prostate cancer?
Prostate-resistant prostate cancer, it's a very high-risk prostate cancer wherein there is a biochemical and radiological progression of the disease, even with testosterone less than 50. Biochemically, the PSA should be raised more than 2 nanogram per deciliter, and this can be checked in 3 consecutive blood tests with 1 week apart, and at least 2 of these blood tests showing more than 50% of the nadir. And radiological progression can be with 1 visceral metastasis and 3 or more than bony metastasis with 1 metastasis outside the axial skeleton. This is based on RESET protocol.
Do you know what is RESET?
It is something to do with the solid organ. Sorry, I don't remember the expansion of it.
Okay, it's an abbreviation for response evaluation criteria in solid tumors.
Yeah.
And this definition, when you're explaining, it is biochemical progression or radiological progression. Even any one is enough to label the patient as CRPC. And for the radiologic progression regarding the bone lesion, 2 or more new bone lesions, not
Yeah.
3. So how will you treat the patients who has castrate-resistant prostate cancer?
Um, this depends on. I would check his testosterone to see if this is castrate resistant to start with, and his PSA. I would check. I would get a staging CT scan again and bone scan to quantify their metastasis. And this also depends. The whole treatment depends on whether this is a non-metastatic CRPC castrate-resistant prostate cancer or metastatic castrate-resistant prostate cancer. If it is a non-metastatic prostate cancer, then the further discussion would be patient and clinician shared discussion, wherein there are options of surveillance with PSA monitoring, or further options of adding apalutamide or enzalutamide or even darolutamide medications. And this is based on large clinical trials, namely Spartan trial, Prosper trial, and Aramis trial, respectively. With regards to metastatic CRPC, again, this depends on whether the patient is fit and has he had any previous chemotherapy. If patient is fit and if he has had chemotherapy in the past, he will be eligible for further chemotherapy medication, which would be apalutamide, cabataxel, enzalutamide, and if he's not fit for, if he is not had chemotherapy in terms of docetaxel, he will be eligible for docetaxel.
Okay, so for those who never had docetaxel, the choice is docetaxel. For others, we can try abiraterone with prednisolone or enzalutamide or cabazitaxel. The newer things like olaparib or radium-223. Radium-223 is more good for patients with metastatic bone mets. Okay, let's complete it with another different scenario. You are on call and the medical team has referred you to a patient because of metastatic cord compression. He's a 68-year-old, otherwise fit man, presented with decrease in motor functions in the lower limb, and he under the care of the neurologist. Examination definitely shows there is decreased strength in the lower limb, and his PSA was 1800. How are you going to treat him?
I'm concerned as this patient might have got significant cord compression secondary to metastatic prostate cancer, with PSA being very high, around 1800. I would go and see him immediately bedside, and I would want to take a history examination and further test of his blood test. Initially, after history and examination, I would want to establish if he has received any medications for his problem at present. Otherwise, I would start him on dexamethasone 16 milligrams as a stat, and also give him degarelix, which is a LHRH antagonist at 240 milligrams as a stat. I would go and organize a MRI whole body, MRI whole spine to rule out cord compression. And depending on the results, I would get in touch with the spinal decompression team or spinal surgical team, along with radiation oncologist to decompress the spinal metastasis.
So explain the GnRH antagonist which you started to say.
A GnRH analog, antagonist. This acts on the hypothalamus pituitary axis. It inhibits LHRH, GnRH or LHRH hormones, and thus decreases the testosterone in the body, which takes normally about 3 days to work completely.
Is there any other method by which you can achieve this?
Yeah, if the patient is fit and can go to theater, I would counsel him for surgical castration, given him more information about surgical castration, which is bilateral subcapsular orchidectomy.
Okay, what is the advantage of subcapsular orchiectomy compared to, say, radical orchiectomy or complete orchiectomy?
Subcapsular orchidectomy, it's done through scrotal incision. He will still have his tunica albuginea, which forms after a subcapsular orchidectomy, which forms a little bit of hematoma, which can be a potential psychological benefit for the patient in terms of having feeling of having testicles. And in comparison with the medication, this is one-off and acts immediately on the same day. Takes about 8 hours to act.
What is the dose for GnRH antagonists?
It would be started at 240 milligrams, and further continuation would be 80 milligrams once a month.
Any side effects?
The side effects are similar to the other androgen deprivation treatment, which is LHRH analog, which would be fatigue, mental health disorders, cardiovascular problems, along with thromboembolic episodes, decreased libido, erectile dysfunction, ejaculation problems, and osteoporosis.
And also the injection site inflammatory reactions, or it could be quite allergic reactions could be possible. Okay, what other medications or treatments you should keep in your mind when you're treating a patient with prostate cancer metastatic cord compression?
The other medication is most importantly dexamethasone, which is given in this place is 16 milligrams stat, and it should be repeated every day until the cord decompression happens about 16 milligrams once daily. This also should be covered with PPIs for the stomach mucosal cover, and analgesia. I can't think anything more.
Yeah, bone specific, you can give bisphosphonates.
Yes, yeah.
The decompression can happen. If it is not happening, we can plan for radiotherapy related decompression or surgical decompression, which you already started to tell you. Good. Yeah. Nice presentation. Anything you want to add, Sachin, before we complete?
I'm not sure, Mr. D. I think this time I think my mind was going too fast than my I could tell you. So I was I think I was a little not linear with my management issues and things like that. It was not. I could have managed my answers very well, but I think I covered everything.
I think you covered very well. There is no major lacunae. There is no major red flag signs which is like worrisome. Obviously, this topic of locally advanced prostate cancer, metastatic prostate cancers, were a lot of areas covered by the oncology colleagues. So that's why possibly you may be slightly weaker because you're not doing it clinically every day in and a day out. So again, form a kind of a clear picture of various pathways for intermediate risk prostate cancer, high risk prostate cancer. You are okay with your values. I don't think you need to work anything more. But if it is like metastatic cord compression, do not forget bisphosphonates or bone basic things. For example, nowadays radium-223 is a very bone specific treatment. So those patients will get better with that. And when you're doing the blood values, you should make sure patient had enough amount of calcium and vitamin D, which is good for the bone health. So those kind of general things you should not forget. Clearly differentiate and understand docetaxel, which is now well established, and understand the newer things like apalutamide and the orapneb and enzalutamide, which is relatively new. I'm happy that you have clearly differentiated between non-metastatic CRPC and metastatic CRPC. That's very important. And any patient who haven't had chemotherapy in the past, like docetaxel, the first step is to try docetaxel. But if they've had docetaxel in the past, then you can try abiraterone, enzalutamide, and other things. There is one clause in the NICE guidelines which says if the patient had abiraterone in the past, they can't have enzalutamide because both are anti-androgens. If they failed abiraterone, means the chances of further failure with enzalutamide is very high. So especially, but if you see the consequences privately, we can give any tablets in any consequence. But just keep an eye on what the NICE recommendations also, so that we are following that strictly in the NHS setting. I'm happy with that. No major concerns, just a little bit of brushing here and there. You'll be absolutely fine.
One thing, Mr. D, about the CRPC or any metastatic workup, should we have to bring in the palliative team as well in terms of comment about that at all?
Yeah, not in the initial diagnosis of CRPC, because we expect with starting of docetaxel, patients should improve, and with starting of abiraterone or enzalutamide, patients should improve. Before I forget, whenever you say abiraterone, please include prednisolone also.
Prednisolone,
yeah, because then there will be a window of maybe even sometimes 12 months before patients becoming very sick. So palliation comes into a place only when these medicines like docetaxel, abiraterone, enzalutamide, they also fail, and you have no other drugs available, and the patients still have excruciating pain. Those are all the areas where we can bring in the pain team or palliative team, because you are running out of options. And also patient's performance status should be 3 or 4 for a palliative team to come in. Usually in the exam, palliative team will come only in the end of scenarios, because even with metastatic cord compression, we try to treat them and we try to give radiotherapy at the maximum to make them ambulatory and make them not in requirement of palliative treatment, at least for 3 to 6 months time.
Okay.
Good. Okay, if you have no other questions, can we complete today?
Yes, please. Thank you so much. I appreciate your time.
Welcome. I'll send you the message regarding my next availability. You can select whichever table you want.
Thank you. Thank you. Yeah.
Have a nice evening.
Thank you. Bye-bye.
Bye.